Okay, cool. All right. Yeah, just in case you guys want to go back. All right. So we'll get started. The goal of this talk is to go over common fractures that we're going to see in the emergency room and how to manage them, uh, X-ray reads, reduction techniques. I encourage any questions at any time. This is a lot more effective if you all bring up uh, like questions that you have or things that you may not be familiar with. We have a bunch of different people as far as their levels of expertise here. We have some, we have some PAs that are very experienced that have been doing this for years. We have some people that were, fresh out of school, and we have people in the middle. So there's really no such thing as a bad question. It's probably something that someone else is thinking of. And, this is definitely the place to talk about it. So we're going to start out by going over how to look at certain X-rays, what's normal, what's not, what makes a good X-ray, what doesn't make a good X-ray. Um, and when you see that X-ray, what's the diagnosis? When do we order something else, like a CAT scan or an MRI, or you need a better view? And then when you look at that X-ray, okay, is that X-ray, is there a fracture? Is there not a fracture? Is there a fracture somewhere else? Is that fracture okay? Can that be sent out of the ER as it is? Does it need to be reduced? Does it need to be splints? And then if you do a reduction, like what is an actual good reduction? So when I was putting this together, I wanted to cover as many topics as possible, but you don't want to be drinking out of a fire hose, so to speak, where there's, all this information in one talk and you don't really pick up anything as opposed to maybe breaking things up into a couple of different segments, hopefully covering the topic adequately, and then another time we can go over something else. So today, we'll do the upper extremity fractures, the humeral shaft, proximal humerus, and distal radius fractures with a pretty big emphasis on distal radius fractures or wrist fractures. And then we'll also talk about some ankle fractures. And then on another date, we can go over other common things that you see in the ED, like hip fractures, femoral neck, intertroch, basicervical femoral neck fractures. When do you book a hemi? When do you book a total? When do you book a nail? Femur fractures, that could be femoral shaft or distal femur fractures. I feel like we see a lot of those. And then some, dislocations, hip dislocations, shoulder dislocations, elbow dislocations. And, we can kind of go over reducing them. And then at another date, we can go over emergencies, like what's compartment syndrome, what's neck fash, when you see an open fracture, like, how do you manage that? And then we can go over maybe some OR techniques that would be helpful for you when you're in the operating room, whether you're given the autonomy to do something or a way to help out the attending. And then once we kind of go through all these things, then I'm thinking, well, I'll find a room at Ocean Medical Center and we can do some splinting and some hands-on stuff. And Stryker Trauma is going to sponsor that. So obviously, please ask questions at any time. You can either unmute yourself and ask, or I don't know if there's a way to just unmute yourself and ask because it's easier. I might not see the hand raise or anything else. So first topic is distal radius fractures. So the mechanism usually a patient falls out on an outstretched hand. The impact usually causes a fracture at the metaphyseal aspect of the bone. That's the weakest area of the bone. Usually the fragment is dorsally angulated relative to the proximal fragment. We call that an extension type um, distal radius fracture, but also the fragment can be volarly angulated, which is a flexion type. Um, why do we reduce these? Well, during the mechanism of injury, the normal anatomy is disrupted. So blood flow can be compromised if the fracture fragments are displaced. There can be skin compromise. That fracture fragment is now pushing on a piece of skin, whether it be volar or dorsal. Those nerves are also being compressed or aggravated or disrupted in a way, especially the median nerve. The median and ulnar nerves are both in very close proximity in that area. And if there's a lot of swelling and the anatomy isn't restored, then damage can happen to the nerve. We call that acute carpal tunnel syndrome. And then, it's painful. So, when something is unreduced, a patient usually has, um, a significant amount of pain. So these are the more common types of distal radius fractures. Um, on the left over here, can you see my screen? Can you see my mouse?
Yeah, we can see it.
Okay, cool. All right, so right over here, this is a dorsally angulated extra-articular distal radius fracture. You can see the distal fragment fractures right over here. You can see that the distal radial ulnar joint, or the DRUJ, is dorsally angulated, meaning it's pointing towards the back of the forearm, or the dorsal aspect of the forearm, and this is the carpus. And then the proximal fragment's right over here. So this is a dorsally angulated distal radius fracture. Over here is a volarly angulated distal radius fracture. So this patient probably fell on a flexed wrist. Okay. And you can see that the carpus is translated anteriorly or volarly. And this normal angle is angling to your left, where towards the volar aspect. So this is a volarly angular extra-articular distal radius fracture. So if you wanted to reduce a dorsally angulated distal radius fracture, you would bring this fracture fragment volarly. And if you wanted to reduce this, you would want to bring this into extension, actually. Um, the third image on the right, the third from the right is a what we call a shear fracture. So sometimes it's not dorsal or volarly angulated. It's more of an impaction injury, and the bone actually shears. So right over here, you can see that there's a fracture line kind of going from posterior distal to anterior proximal, and the carpus, the carpal bones are actually translated anteriorly, and they've shortened. So this is, we would call this a dorsal or a volar shear fracture. These are very hard to reduce because you can imagine even if you pull traction on this, there's nothing keeping the carpus from pulling back down because the volar and dorsal musculature are going to pull the carpus proximally. So this is actually a very hard fracture to reduce and probably needs to be fixed surgically. And then over here, you have an intra-articular fracture. So you can see right over here, there's a fracture step off, and then you also see the radial styloid is also shortened. This is actually what we call the die punch fracture. But basically, what you need to know is that there's one, two, three, four different types of fractures as a broad as a broad classification, but all of these are different morphologies of distal radius fractures. There are a number of classifications. Obviously, there's no reason to memorize all of these. You can read them at your pleasure, but the reason I added this in here is, there's a number of different ways to classify these. There's also predictors of instability. They're called LaFontaine's factors of instability. If a patient were to ask you, like, does this need surgery or doesn't need surgery, there's also criteria that we use for that. It's not necessarily super important when reducing them, but just know this is a very common fracture, so there's a lot of literature into classifying these fractures. So this is a lot of these X-rays that I'm going to show you are actually from when I was a resident. Um, does anyone want to take a stab at reading this X-ray and telling me what you would tell me or one of the other surgeons over the phone when you have this X-ray? Katrina, why don't you take a stab
I'll
at it?
go for it here.
Oh, go for it. Okay, who's that? Is that Mike?
Yeah, you can give it to Katrina though. It's all good.
Okay.
Um, doesn't look dorsally or volarly angulated, so my guess would probably be a shear fracture or
Okay.
like some sort of impacted fracture.
So it's definitely impacted. I agree. So I would say that if you look at the AP, it doesn't really look like there's a ton of translation medial or laterally. So I agree with you. It's probably impacted. If you look at the lateral, um, this isn't a great lateral. And the way you tell if a lateral is a good lateral or not is basically if all of your carpal bones are lined up. And I know it's a little bit blurry, but if you look at this, you can actually see how there's a little bit of dorsal angulation with this fracture, and it is extra-articular. So I would call this an extra-articular dorsally angulated distal radius fracture. And you can obviously see over here this patient's on, she has some osteoporosis or he has some osteoporosis. The bone looks a little loose, and there might actually even be a fracture line extending down into the metaphyseal diaphyseal junction. Okay. So now the question is, if you see this fracture, does this need to be reduced or doesn't it? I'm not sure. Um, is it something that if we left it and it were to be surgically fixed, would it be okay? Could it heal this way? That's what we're going to kind of go over. So good job, Katrina. So why do we reduce a fracture? Any kind of dislocation, when the displacement is not acceptable as far as reduction criteria, and we'll go over those. And we want to stabilize the soft tissue prior to operative treatment. If you reduce a fracture, you bring it back into alignment, put it into a good splint, you're protecting the soft tissues so that, a week down the line or a week and a half down the line, when a surgeon can get to it, the soft tissues are amenable to surgery. If they're dislocated or if they're um, in bad position for a week, it's going to be that much harder for soft tissue handling. So a normal inclination as far or a normal anatomy for a distal radius fracture, there's a couple of numbers. There's radial inclination, volar tilt, radial height, and ulnar variance. Basically, what you want to do is you want to try to restore the normal anatomy as closely as possible. You want to make sure that your radial inclination and your radial height are as high as possible, and you want to make sure that your distal fragment has the appropriate volar tilt. You don't want to be dorsally angulated. Intra-articular step off, you don't really need to worry about because it's very hard to fix that when you're doing a reduction, but that's more for surgical planning. But if you look at this image over here, this is kind of what we use when we're talking about these parameters. So you can see over here, the inclination is basically the angle that the distal radius and ulna make, measuring from the radial styloid down to the base of the lunate facet. Okay. That line is your radial inclination. So if you look over here, the radial inclination is pretty horizontal. So there's loss of height there. Okay. Radial height and inclination, you can see over here, they're kind of measuring the same thing. The higher your radial styloid is, the better. So over here, the radial styloid has kind of lost its height. So that's not really that good. And then over here, volar tilt, the natural anatomy of the distal radial ulnar joint, there's a little bit of a volar tilt to it. So if you look over here, you can see how that joint surface is angling backwards. So according to these parameters, this fracture would not be acceptable to send out the way that it is. You would want to try to reduce it or make it better. Okay. So this is from the AO website, but the basic principle for reducing a fracture is to bring it, back to normal anatomy. The technique in most cases is to recreate the deformity, distract, and then apply an opposite pressure. So if you look over here on A, you can see it's a dorsally angulated distal radius fracture. There's traction and recreation of the deformity. Okay, you're making it more dorsally angulated. And then you're going to, while still applying traction, volarly angulate the fracture. And I'll show you a couple of ways of doing this. Um, Basically, what you need to do is you need to have a mechanism for applying traction. You need to have a mechanism for translating this distal fragment into the correct position, and then you need a mechanism to hold it in place while you place your splint. Okay, so when you're reducing a distal radius fracture, the first thing that you're going to do the first thing you always do is a good neurovascular exam. Okay. You want to make sure that you assess if the skin's bleeding. You want to make sure you assess the neurovascular status, check the radial nerve, check the median nerve, check the ulnar nerve. Okay. Basically, you want to do a good physical exam because if you do your reduction and all of a sudden the patient says, "Oh, for some reason, like my thumb, my forefinger, and my middle finger hurt a lot, and it's getting worse," or they're numb, or I can't move my small finger, you're gonna wonder like, "Oh, well, is that because of the fracture, or is it because of something that I did?" And if you know your exam beforehand, then you can go back and say, "All right, this was present beforehand, the reduction did or didn't do anything." But if, say, they were completely fine and you did a reduction and all of a sudden they're having a neurovascular compromise, then you know it's because of the reduction, and you may need to either re-reduce or you might need to bring them to the OR emergently. But it's always good to have a good exam before you do the reduction procedure. A hematoma block, in my opinion, is the best kind of analgesia. All right. Um, when I do my hematoma block, I usually ask for 10 cc's of lidocaine, 1%, with or without epinephrine. It doesn't really matter. With epinephrine, you'll get a little bit more time, but that's all you need. I'll show you how to do a hematoma block, but basically the easy way of doing it is, the patient's usually sitting there in the ER or laying down with their hand on their midsection. All you do is you take your thumb and you just lightly palpate where the fracture usually is, and you'll feel a little bit of crepitus on the dorsal aspect of their wrist. That's where you put the needle. Okay. And what you want to do is you want to insert the needle. When I was a resident, I would use like a 21 gauge or even an 18 gauge needle, depending, because you're going to get a good amount of blood flashback into the syringe. And then that lidocaine is going to go right into the fracture site and it's going to numb the patient up a good amount. Then you're going to recreate the deformity, traction, volar translation, and you're going to flex and ulnarly deviate the wrist. So this was somebody I sent out a video of a distal radius reduction, but this is from the video. You can kind of see even to the naked eye, you can see how there's a deformity to this patient's wrist. She has an extra-articular distal radius fracture, and there's actually some swelling and some discoloration from that fracture fragment. So it was pretty easy to do this hematoma block. But basically, all you do is you clean the area very well. Alcohol, betadine, chlorhexidine. Make sure that the skin is very clean. I have a 21 gauge needle here. I usually, if you have a 10 cc syringe, it might be a little bit too small. The reason I say that is you need to allow for some fluid to come back into the syringe when you're doing your aspiration. So usually what I would do is I would ask for a 20 cc syringe and fill it with 10 cc's of lidocaine. So now you have 10 cc's of dead space, so to speak. So when you aspirate, you can easily pull 5 cc's of blood, and then you're in the right place, you're in the hematoma, and then you can inject all 10 cc's into that hematoma fracture site, and you have plenty of anesthetic. So you do this, you should see a flashback, inject, and then honestly wait a good 60 to 90 seconds. Let that hematoma set up. You do this. The other thing that I would do is have some gauze ready, because a lot of times some blood will ooze out of that area because you know you there's an increase in pressure over there because there's a fracture. While that anesthetic is working, you're going to go over and grab your splint materials. Now, when I was a resident, we did everything with plaster of Paris. You can also use orthoglass. It doesn't really matter. I trained with plaster, so I'm more comfortable with it, and I feel like it's a little bit easier to mold. The orthoglass sets a little bit quicker, so it's up to you. But usually, you're going to use 9 to 12 layers of 3-inch plaster, web roll or soft roll, and then ace wraps. And then the big important thing is a 3-point mold to maintain reduction. So what I usually do is I measure out the use splint on the patient, or I use myself. I'm 5'10" and I'm a normal size guy, so usually if I measure it on myself, it's big enough for most patients. If they're a very large individual, then make it a little bit larger, because you can always cut the splint after you've applied it. And then what I usually do is I lay out 5 layers of soft roll. I lay the splint on top of it. I get my ace wraps ready, and I'm nice and organized. And then once I do the hematoma block, I dip this in water, warm water. I wring it out. I put the splint on the soft roll, and then I put 1 layer of soft roll over top. So now I basically have a sheet, and I put the 5 layers up against the skin, the 5 layers of soft roll from the volar aspect of the hand all the way up to the dorsum where the metacarpal heads are, and I'll show you where that is. But this is what a reduction should look like. Okay. Now I picked this X-ray because there's both good aspects of it and there's also imperfections. So if you look over here, the volar tilt is pretty good. This is your radial shaft. Okay, and you can see that you have a good amount of volar tilt. You've restored some radial inclination and height. So overall, this is okay to send out. The things that I didn't do very well here is you see how the hands are pointed, the metacarpals are pointed straight up in the air. They should be pointed more ulnarly, and I would have gotten a little more radial height. And the other thing is you can see there's little rivets over here. Okay, that means that I was probably pushing on the splint while it was drying instead of holding it. And those rivets, they're not the end of the world, but they can be a little bit irritating. Um, we're kind of nitpicking. This would have been perfectly fine to send out, but that's what a splint x-ray should look like. This is an 88-year-old female that fell, has a very severely dorsally angulated distal radius fracture. You can see, the radial shaft and the distal fragment aren't even touching, and they also have an associated ulnar styloid fracture. And this is another reduction technique. This is another reduction. Again, there's a little bit of an imperfection over here, and you can see. I'll kind of let's see if I can make this any bigger. You can see over here that now the question is, is this okay to leave and let them heal this way? I think it's okay. The volar tilt is probably neutral, not necessarily as good as this one. You can see this one probably has about 10 to 15 degrees, but it's still acceptable. It's neutral. And your splint is going to come basically up to the first palmar crease and up to the metacarpal heads. You don't want it to go any higher because it interferes with finger flexion. Okay, but you don't want it to be so low that that it doesn't actually stabilize this fracture fragment. So Katrina was nice enough to help me with this in the office. This is the what I call the I don't even know what I call it. You just put your this is the one person technique. This is make it all happen yourself. We did this as residents because we didn't have any assistants. But basically what you do is after you do your hematoma block, you stand at the patient's head, you face their feet, and the leg that's closest to the body, you bring that leg up in the air in a flex position, and you bring their arm underneath your leg, and you basically bring your popliteal fossa, the back of your knee, and you actually put that right up against their antecubital fossa. And what you're doing there is you're manufacturing distal traction. And you're using your body weight and you're using your leg, which is very, very powerful. Now you could see over here that my thumbs are on the distal fragment where the fracture is, and you'll be able to feel this. And basically, what you do is you pull traction, dorsally angulate, so you extend the wrist, and then you bring the hand back volar, and you should feel a little bit of a click. Now, the hard part after this, believe it or not, you have to kind of transfer your hands. You hold the distal radius fragment in your right hand, and basically what you do is you pass the arm underneath your leg, grab it with your other hand, and then lay it down on their midsection. Okay? It takes a little bit of practice to do this. And like I said, it's not the easiest thing to do, but if I probably did about 1,000 of these in residency, so you kind of get a little bit more proficient with it. But you lay that hand on their midsection, you tell them don't move. You go over to your table where you've dipped your splint in the water, and you basically wrap the arm in the splint. And you basically, this is how you should look. Now, obviously, there was no plaster here, but this is how you start. You then gently ace wrap, okay? And during this procedure, you're probably wondering, well, like, how do we prevent the fracture from moving? The fracture probably does move a little bit, and that's okay because if you've brought the distal radius fragment up and over, and it's kind of it's hooked and it's impacted back over top of the shaft, it shouldn't move that much as long as the patient's not moving a ton. And then you're going to do your 3-point mold. So mold point number one is their elbow up against your leg. Mold point number two is your hand right on the volar aspect of the forearm. Okay. Number three, and this is important, is not on their hand, not on their wrist, but actually just proximal to their wrist where the fragment is. Because if you put your hand over here, what you'll do is you'll hyperflex their wrist and you'll compress actually, and it can cause, median nerve symptoms. You want your hand just where the fracture fragment is, and it takes a little bit of practice to know where to go. But you want to make sure that One, elbow up against the leg. Number two, hand up against the forearm. And number three, um, you know, your last hand on their distal radial fragment. And you're going to hold this until it hardens. And they may be moving around. They may say like, "Oh, I'm a little bit uncomfortable." But the important thing is to hold until the fragment or the until the splint is hard. And then what you can also do as you're molding this, you can take this hand and gently ulnarly deviate the fingers. And what that will do is that will give you your ulnar deviation. And basically, you hold that there until they're reduced, and then you take an X-ray. All right. So that's distal radius fractures. Any questions or comments?
I got one.
Shoot.
Do you normally with the fiberglass splinting material, do you normally wet it with the soft material on, or do you take it out of the soft material?
Oh, the orthoglass? Um,
Yeah.
I'll be honest with you. In that situation, I haven't done too many with orthoglass. I would probably maybe put, one or two more layers of soft roll on it. Because you don't you want whatever goes up against the skin to be dry. Um, because if you're gonna do the technique that I showed you where you're making it basically one sheet, whatever goes up against the skin needs to be dry because the skin will get macerated if it's sitting in a wet splint, so to speak. Like the exothermic reaction will heat it up, but I would put a layer or two more to make sure it's not wet underneath.
For those shear fractures,
Yeah.
typically I'll ask the ER to like hang that from the finger traps with a little weight off the elbow and then just splint it while it's hanging.
Yes.
Um, and typically, I mean, it'll pull it back out to length somewhat, but like you said, it'll fall. It'll fall back
100%.
down. Is that typically what you do if in
Yeah.
that situation?
100%. Yeah, it's a great point. So, the shear fractures, they're really hard to reduce. The only thing that you can maybe do in those situations is you can do a little bit of a pancake where you kind of put a little bit of pressure volarly and dorsally and kind of try to mold the splint so that it prevents that shear fracture from falling. But you're 100% correct. Almost any shear fracture is going to be operative. And I think in that situation, just having a snug splint that because what you want to prevent, not all shear fractures are going to look like this. Some shear fractures, the fracture is right here. Okay. And then that actually produces something called a radial carpal fracture dislocation. And those can be dangerous because you can imagine the carpus kind of falls into the carpal tunnel and it's much more serious. But yeah, like you said, Matt, just traction and kind of a gentle but snug A to P compression can kind of help that fracture stay. But those are usually operative, and depending on how bad and how unstable they are, that is up to the surgeon. But I would check with someone before sending that out because the last thing that you want is for them to show up, 3 or 4 days later in severe pain in the office and their carpus is kind of subluxing volarly into the median nerve, and that can be pretty bad. Or they're trying to call the office at 1 o'clock in the morning and they're coming back into the ER. Doesn't happen very often, but you just have to be aware of that. That's a good point.
Got it.
Now, the other thing that might be coming up is, okay, I tried to reduce the fracture and it doesn't look like this, but it doesn't look perfect. And is it okay? Um, so you kind of get a sense for um, you know, is it in the ballpark? Is it not? I would say before sending out a fracture, I would be careful about sending out a fracture that's dorsally angulated more than 10 degrees. If it's something that, the surgeon says, I'm going to fix this in a week, and it's kind of just slightly dorsally angulated, it's probably fine. If it's neutral, it's fine. But what you don't want is you don't want something dorsally angulated 20 degrees or something that's dislocated. Or I would not send out this fracture. I wouldn't send out this fracture. I think this one's actually okay to send out. But extremes like this, these criteria that I talked about over here, um, I would just be careful about, sending something out that's really at the extremes of this. But if you're unsure, just always shoot a text to the surgeon. Um, and I mean, you can always if I'm not if I'm not out of town, you can always reach out to me. I'm always happy to just give an X-ray a quick look and see if it's okay or not. And then eventually, someone like Matt who's been doing this for a long time, you have an idea, you have experience. But if you're not and you're not sure, just ask. All right. You guys okay if I move on to humeral shaft fractures and everything else?
Yeah, do it.
Okay. All right. Humeral shaft fractures. We're going to go through the humerus fractures a little bit quicker, and then that way we have enough time for ankle fractures. All right. Humeral shaft fractures. They can be both low and high energy. The things that you need to know about these that's important is where is the fracture? Is it proximal? Is it mid shaft? Is it distal? The reason that we're going to ask about that is depending on where the fracture is, there's an incidence of radial nerve injury. So your radial nerve, remember, controls the sensation over the dorsum of your wrist, your ability to extend the wrists, and extend your fingers. Um, when you're doing a motor exam, every single humeral shaft fracture, you have to do a good radial nerve exam, and the reason is a um, there's an incidence of 2 to 9% of radial nerve injury in distal fractures. We call it a Halstein-Lewis fracture. Um, those can be a much higher rate of radial nerve injury. And what you want to know is if, like, let's say you go in and a patient has has a humeral shaft fracture, and then 3 or 4 hours after you've either splinted them or put them into a splint, or they go home and they come back to the office, and one of the surgeons is doing an exam and their radial nerve is not working, they're going to want to know, hey, was this out in the ER? And if you're not sure, then there's a little bit of a question. Was it because it wasn't reduced? Was it because it was reduced? It's always good to do a very good exam. When you do an exam, don't ask the patient to extend their thumb. What you need to do is you need to make sure that the patient extends their wrist. Ask them to move their wrist up and down. Um, and then, if anybody were to ever ask you the location of the nerve, just remember football scores. It's 21 centimeters from the medial epicondyle and 14 centimeters from the lateral. But it's just one of those, little tidbit. Um, um, but anyway, as far as reduction, um, the patient is placed into a coaptation splint or a Sarmiento brace. Um, the treatment can be operative or non-operative. It depends on whether or not it's some people, some patients are, or some surgeons are more conservative. They want to treat these in a brace. Some are more aggressive and they'll fix them. There's no real right answer. Depending on the literature that you um, depending on the literature that you read. But let's take a look over here at an X-ray. So this is a mid-shaft humerus fracture. Um, you can see over here that the fracture is, mid-shaft. We call it a distal mid-shaft fracture, but this is about as mid-shaft as it gets. This is what a coaptation splint looks like. Um, if if you look at this, I would say it's pretty you know, it's pretty decent. Um, I think that um the overall alignment is good. It's obviously a little bit distracted. It might be a little bit dorsally angulated, but at the same time, if you were to send something out like this, it would be fine. Um, the materials to put a coaptation splint on: 4-inch plaster, 5 layers of soft roll, basically the same thing that we talked about. Stockinette. What I usually like to do is I put the splint inside of a stockinette. That way you can kind of tuck it up into the axilla, wrap it around the shoulder, and then you can wrap it, and then an ace wrap. Um, the goal of reduction is 20 degrees of angulation in the less than 20 degrees in the anterior posterior, and 30 degrees varus or valgus. This is pretty straight. What I will tell you is that the coaptation splint, usually you want to switch out to a Sarmiento brace as soon as possible. If you can get this in the ER, then it's a huge win. Um, if you can't get this in the ER, put them in a Sarmiento brace, try to have them follow up within a week and put this on. And then operative treatment, like I said, it can either be surgical plating or intramedullary nailing. Um, let's see. Um, the next fracture that we'll go over is proximal humerus fractures. These are fragility fractures. They can be 2, 3, or 4 part. That's something called the near classification. What's important? Basically, when you get called about a proximal humerus fracture, you just want to know if it's dislocated or not. And there's only two ways to tell. There's an axillary or Valpo view or a CT scan. Almost all of these you can place into a sling. If there's operative fixation that needs to happen, you either can fix it with a plate or screws or do a reverse total shoulder. So these are two different x-rays of proximal humerus fractures. Which one of these is emergent? I think if you look at these closely, you can tell obviously that this fracture is pretty bad. Okay. The humeral head is dislocated anteriorly and into the axilla. When you see something like this, it's an emergency. You need to give the surgeon a call. You need a CTA because when if you tried to pull this out, you could, cause neurovascular injury. It could be pretty bad pretty quick. But obviously, this is a fracture dislocation. This most likely isn't. So how do you know? This is an axillary view. This is a CT scan. What you want to see is you want to see the humeral head within the glenoid. Okay, the glenoid is right here. The humeral head is right over here. This is from ortho bullets. This kind of outlines the different structures of the shoulder, but you want this humeral head surface to be articulating with the glenoid. Okay, if they get a CT scan, that's fine. But as long as you see this, then the shoulder's okay, and you can usually send it out. Any questions on humerus fractures? No questions? Okay, good. All right. All right, ankle fractures. Oh, okay. So basically the last thing that we're going to go over is ankle fractures. These can be really tricky, and I think that this is probably one of the harder reduction challenges that you face. Ankle fractures can be very humbling. Okay, as a resident, even as like a senior resident, um when I had a number of these under my belt, there were some ankle fractures that were very, very hard to reduce. So I definitely have sympathy for that. But basically what you need to do is you need to know, is it reduced or is it not reduced? And is it something that's okay to send out? So they can be high or low energy. Usually they're rotational. There are soft tissue implications, the deltoid ligament medially and the syndesmosis between the tibia and the fibula. There are rotational ankle fractures, and then there's tibial plafond fractures, also known as pilon fractures, that are very high energy that should never be sent out. This is a rotational ankle fracture. This is a pilon fracture. Something like this should never be sent out because it swells extremely fast. This is what the articular surface looks like. This needs to be put into an external fixator or acutely fixed. But this should never get sent out unless the attending tells you specifically to send it out. This, if it's reduced, can be sent out and fixed later. Okay. So when you're looking at an ankle x-ray, work through it. The first thing you do is you look at an AP. Look at the fibula. Is there a fracture? Yes or no? Is there a space between the tibia and the fibula? Like, is it diastased? Look at the medial malleolus. Is there a fracture? If there's no fracture, is the space between the talus and the medial malleolus very, very apparently wide? And then you look at the lateral. Is the talus underneath the tibia, or is it sublux anteriorly or posteriorly dislocated? Most of the time, in most rotational ankle fractures, the tibia is translated anterior um, to the talus. That's usually what happens. And then is there a posterior malleolus fracture? So these are these are the main ankle fractures that you're going to see: supination adduction, supination external rotation, pronation abduction, and pronation external rotation. This ankle fracture is the most common. This one is the hardest to reduce because it's unstable. It's the shear fracture of the ankle. Okay. These both have a very high incidence of syndesmotic injuries and they can be very unstable. Okay. This is the Loggy Hansen classification. I got this off Ortho Bullets. You guys can look at that, at your own pleasure. But just so you know, there's like a sequence of failures with um, that happen with these ankle fractures. Um, so if there's a medial malleolus fracture and no fibular fracture, or there's an ankle dislocation without a fracture, always X-ray the knee. Okay. These X-rays are an hour old. Okay. One of the PAs sent these to me because we were talking about, he was asking me about reduction, and it's a very tough, it's a very tough reduction. This ankle is very tough. It's very unstable, but it was kind of serendipitous because this is a fracture. If you look at the reduction films over here, you can't really see a medial malleolus fracture and you can't really see a fibula fracture. But when you x-ray the knee, you can see a proximal fracture. Okay, that's called a Mason-New fracture. Very unstable. The syndesmosis is completely disrupted. I probably wouldn't send this out, and this needs to be fixed. But you can obviously see, you look at it, you would call this and say, oh, this is a pure ankle dislocation, but it's not. The energy actually started medially, ripped his whole interosseous membrane is disrupted, and then the energy exited his fracture over here. But if you ever see an ankle dislocation and there's no fracture on the medial side, always get a knee or a tib x-ray. Okay. So this is what we would call a trimalleolar equivalent ankle fracture. All right. The medial malleolus has a small chip, or no chip at all. So we would say maybe there's no fracture of the medial mal. There's a posterior malleolus fracture right over here, and then there's a fibula fracture. And I would actually call this a fracture dislocation because the talus is, like we said, it's posterior to the tibia. The tibia is anterior. The plafond is not over the talus. So what you want to do is you want to reduce the fracture with a 3-point mold. So we're just going to go over real quick how I usually do this. Okay. An AO splint consists of a posterior aspect and a U aspect. So what I usually do when I'm alone is I have the patient sit on the bed. I have them dangle their legs over. I do a hematoma block. The hematoma block usually is a needle just medial to the tibialis anterior tendon. But basically, what you do is you go as medial as you can on the ankle. And in a fracture dislocation, it's very easy. The needle should go straight in, but you're doing it basically the same way you would aspirate an ankle. Okay. Same thing. See the flash, inject the anesthetic, let it go. And I usually roll out plaster. I measure it like this. Okay. And I also measure out my posterior limb. So usually what I do, and this wasn't done with plaster, it was done with soft roll because we didn't have it in the office. But basically what I do is I dip the first limb, I wrap the leg in soft roll so it's very well padded. The first aspect of plaster starts up at the calf, and then what I do is I start to wrap and work my way distal, and then I bring it out and around, basically to the base of the metatarsals. And then what I do is I bring my second limb, my U, and I bring this around into a U. Okay, it usually sticks to the soft roll, and then I wrap it again. And then what should happen is you should have a pretty well wrapped leg just like this with soft roll, splint, and ace wrap. Okay. So your 3-point mold, your 3-point mold for your ankle fractures, your first point, your hand goes just proximal to the medial malleolus. That's hand number one. Not on the medial malleolus, but just proximal to it. Your other hand is going to cup the hind foot and you're going to dorsiflex and you're going to invert the foot. Okay, so you can see kind of how I wrap my hand around the hind foot, not the forefoot, the hind foot, because the hind foot's what needs to be reduced. The forefoot will just kind of torque on like the toes and it doesn't really do the same thing. One, two, and then what I usually do to make things a little bit easier is I call this two prime. I take my elbow of my second hand, I spread my legs apart, and I kind of do like whatever they call those in the gym, like that, like the Pilates machine where you kind of extend your hips. You got to get into that position and you place, and it's kind of funny, but it actually it helps. You put your elbow on the inside of your knee. That way, when you're doing your mold, you're using your legs. You basically drive with your knee and you drive this hand medially. Otherwise, you're just using your arms, and it gets very tiring very quickly, especially with a patient that's fighting you. So you
I don't know why he's barking.
Um, and then number three is your head actually goes proximally up by the knee. So one pushes medially, two closes down the medial clear space, and number three, your head actually goes proximally up by their knee, and that becomes your stabilizing mold point. Okay. So this is what a reduced ankle looks like. And you can see if you do a good medial mold, that's from my hand. Sorry. Let's see if I can make that a little bit bigger. That's what your medial mold should look like. Like basically you try to cave in as as forcefully as you can that medial side, and then you can see where my other hand was right over here, and the hind foot was brought in to close down that medial clear space. And then on the lateral, you want to make sure that the talus is underneath the tibia. Now, if there's a posterior malleolus fracture, the bigger the posterior malfracture, the more unstable the fracture is going to be, because you can imagine if there's, if the fracture is right over here, there's not much holding this tibia from sliding out the front. So you have to make sure that you also dorsiflex and bring the foot up. This isn't as dorsiflexed as I'd like, but it was stable enough. And because it was so unstable, they put a plate and screws on posteriorly to buttress it. Um, this is another Mason-Oof type fracture. You can see that the tibia is anterior to the talus. The syndesmosis is disrupted. There's frank diastasis of the ankle, and this is what a reduction should look like. You see again, there's a very strong medial mold. There's a very strong lateral mold. You can see that like my hand was here, my hand was here, and I also this one is dorsiflex the way you want it. Basically, you want the foot almost with the toes pointed up in the air. And then you can see the talus is underneath the tibia. And this was treated with syndesmotic screws. So that's it. So I think we have like about 10 minutes and we can kind of go over questions, comments, anything else that you guys want to talk about.
Do you prefer doing like full blown anesthesia for this in the ER with like propofol, or do you always just try to manage it with like a hematoma block and some morphine?
Yeah, it's a great question. I think when I was in residency, because I was speed was important. Like, I would get a number of ankle fractures and wrist fractures a night. And if I had to wait for the ER to sedate everybody, um, it was very time consuming. I don't think there's anything wrong with sedating people, but I will tell you, it is easier to reduce these ankles if the patients are sitting up. Because if they're sitting up, you can use a second assistant, but it's much easier to stabilize the leg because gravity is helping you. Whereas if you have a patient laying on their back, you can do a Quigley, and I didn't go over that, but that's basically when you tie the toes and hang it, and there's kind of a reduction that happens, and you can put a splint on that way. But I would try to do it with a hematoma block. Maybe you can push 2 to 4 milligrams of morphine. Usually those things will kind of numb them up enough. The hematoma block is where the money's at. That's my personal preference. If you're doing this at 1 o'clock in the morning and you're by yourself, it's really hard to do it if they're laying down, and it's really hard to get good help. Like the ER, they may be enthusiastic, but they may not be able to help you the way you want them to. So, um, but yeah, I like to do it without sedation if I can. Nothing wrong with it, but any other questions?
Hey, Doc. So one thing that I feel like is tough to kind of get into
the habit of it is getting like a good like splinting mold and getting it like quickly and done before it either hardens up or making sure that the fracture doesn't move. Do you have any like tips and tricks? I know you said like you try to like prepare everything in the meantime and try to get everything like set up beforehand. Do you have any like other tips and tricks that you like find yourself doing pretty frequently that way it kind of streamlines that? Because I think that's like one for like patient comfort and ease of mind, but also it saves you a lot of time too.
Yeah, so the things that you can do, like you said, organization, have an area where you lay your splint stuff out. The second thing that you can do is have X-ray in the room or right outside. I was pretty emphatic about it when I was a resident. I sometimes I would go like, you're crazy when you're a resident. I would go down. I knew where X-ray the department was. I would go to the X-ray department and I would bring an X-ray tech with the machine over to the patient's room. But what you can do is you can have the X-ray machine there, and when you're doing your reduction, as soon as you feel like it's starting to harden, okay, and you feel like the splint is actually starting to hold, then you put the X-ray plate under it and you take a shot. And you have, and if they're in the, if it looks, the splint looks good, you're done. If it doesn't look good, you don't have to wait for X-ray for 20 minutes to come down there and shoot, and then the anesthetic's wearing off and all that other stuff. So I would have X-ray there, and then you have your images. You know it's okay. You know it's not okay, and then you can whip together another splint quickly, or you can do another reduction. Or if they're sedated, you can do another reduction while they're sedated, as opposed to them waking up and then like you're waiting an hour for X-ray and then it's not good enough, and then you text Dr. Monona and he's like, it's not, like it's still dislocated or it's still sublux, and it's like, damn it, like, I got to do it all over again. So I would have X-ray in the room. That's my other trick. All right. Yeah, so I would just say, if you have any questions, email me. All right. We sent out the invite, Monona at OIB Ortho. Any questions you have on the talk, or you can text me. Almost everyone has my number, or call or whatever. If you're ever jammed up in the ER, just call me. I'm happy to help. I might not be in the area or whatnot, but um, my mantra is if somebody asks for help, then it's you should help them. So I'm always happy to help, give advice. Give a once over on the X-ray. The person that's on call has the final call, obviously. It's up to them what to do. And if you have ever questions, reach out to them. But hopefully this kind of clears up some questions. What's okay, what's not okay. And like I said, a lot of this is going to be experience, but hopefully this gives um, a good framework. I'll try to do another one of these talks if this is something that you all like and you found it helpful. I'll do another quicker talk on hip fractures and emergencies, and then I talk to the striker trauma reps. We'll find a day where we can go over the splinting and obviously, the 3-point mold and how to position and where to put your hands and all. We'll go over all of that in detail. But I figured it would be smarter and easier if we went over the theory and the teaching behind it now, as opposed to doing this like in a 2 or 3 hour session. Then it gets pretty tiring. But at least you can digest this, go back, take a look at it, find things that aren't clear, and then we can go over, the actual technique when we're in the lab. All right. Any other questions, or we're good to go?
No, thanks for putting this together.
Yeah. Cool. Awesome. All right. I'm going to run over to Center State and do a hip nail. I'll see you guys later.
Enjoy.